my mantra you always know, do what I love. And as a teacher, my job is also there to foresee what is new, and if it's worthwhile, give a helping hand and diffuse it. So I think, I came across a novel idea which was sold to me by Trupti Chauhan, who's a marketing person from the GUFIC. And the stalwarts are working very quietly on this particular product. And my job is to give a helping hand by adopting this particular technology and diffuse it in among friends. So I think I take this opportunity to at least 50 people, 60 people I'll be able to impress today. What is it like this? I have no experience of mine. The person who is behind it is Dr. Adarsh Shetty, who is the head of the medical division of GUFIC, and we are lucky to have Dr. Ranjit Joshi, who has got a practical experience of almost 100 cases with this wonder drug. And after my presentation, he's going to give you an insight about this particular thing. So let me just make a presentation. I'm going to introduce to you Thymosin alpha 1 in recurrent implantation failure. To me, it seems to be a wonder drug, and only time will tell that what I'm trying to premise is going to be correct. Everybody wants a baby at least. And for this child, many people will exhaust any and all avenues, financial, geographic, to find a way around. Recurrent implantation failure has become a big problem in these days, and to date there is a lack of clear-cut consensus on the definition of recurrent implantation failure. The definition which we follow is that recurrent implantation failure is the failure of clinical pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen IVF cycles in a woman undergoing by the age of 40 years. The incidence of recurrent implantation failure, which I can see around and know from my friends, varies from 10 to 40%. There is a scarcity of reported data, and that's why we cannot accurately tell what is the incidence and the prevalence of recurrent implantation failure. The prevalence of preclinical abortion rate in natural NART cycles is pretty high, and in a spontaneous conception, it is as high as 70%. And 55% represent a failure of implantation and are therefore not clinically recognized as pregnancies. Failed implantation represents the major limiting factor in assisted reproductive cycles too. This is a slide, which is again $1 million slide. On the left-hand side, you can see the natural spontaneous conception, which we can find nearly 30% soon after fertilization. In the pre-implantation phase itself, 30% abortion take place and 25% take place in a post-implantation phase. And the clinical pregnancy, when it's diagnosed, nearly 15 to 20% abort. As similar is there in ART pregnancies also, where you can find the pre-implantation share is little bigger, post-implantation and clinical miscarriage rate is almost the same. Now, when it comes to the causes, with a knee-jerk reaction, we always blame the lifestyle factor, but इस कहानी में बहुत सारे किरदार हैं. And this slide very beautifully summarizes that beside the age of the woman, poor quality embryo is one of the biggest culprits. And then for this, there are the immunological factors, there are infections, there are genetic factors, there are thrombophilia, and beside going the lifestyle factors and uterine factors. And lately, the male has been also not spared because his poor semen quality and a high DNA fragmentation also contribute significantly. So we can definitely summarize it. There are uterine factors where uterine malformations, intrauterine infections, uterine fibroids, which is distorting the cavity. Embryo factor entails the various chromosomal abnormalities in the embryo, And as for the maternal factors are concerned, again, there are immune disorders, thrombophilia, and chromosomal abnormalities, both in woman and man. You can see in this particular slide, just like recurrent abortions, in 50% of cases, we do not know the cause. But in the rest of the 50% cases, the causes are almost similar what we find in recurrent miscarriages. Now, assessment of causes of recurrent implantation failure is crucial for treatment. So, for making it oversimplified, recurrent implantation failure, there's a maternal factor and there are embryonic factors. And in maternal factors are anatomical factors. Endometrial receptivity is being thought about, because we all know that in case if the endometrium does not become 7 millimeter, there will not be any pregnancy. People have started talking about immunological factors, thrombophilia as a cause for this. As for the embryonic factors are concerned, we all know about the genetic factors. Male factors definitely also contributes to this particular embryo quality. And for many reasons unknown, there are embryo ceases to develop in utero. As for the immune factor is concerned, this plays a key role in successful pregnancy. It's almost like a fashion, and we hardly know anything about it. And that is why we find that in immune system, there is a maternal fetal crosstalk, which we have not been able to decipher as are concerned. But in spite of the implantation, the embryo development is jeopardized, and there's a failure for a pregnancy. Now, this innate immunity has a major role in maternal fetal interface. Most immune cells are, I can say to the tune of 70%, being CD56, natural killer cells, and monocytes. Between 10 to 15% of all cells found in the decidual are lymphocytes, and mainly these are regulatory T cells. Clonal expansion of allospecific uterine and peripheral regulatory T cells together with proliferation of the uterine natural killer cells and dendritic cells are involved in maintenance of immune tolerance to the fetus. So the pathophysiological role of immunological factors in recurrent implantation failure are cytokinin imbalance, the expansion of peripheral natural killer cells, there is a deregulation of uterine natural killer cells, and allorecognition. You find that these molecules, NK cells, receptors, and all have a role to play. Untreated hypothyroidism is also found to be culprit. This slide is again oversimplified, that you find in a circulating immune mediators are there in the peripheral beds. There are ones which are spotted on the left hand side are the ones which cause increase in immunity activation, while on the right hand side cause the immunity gets suppressed or decreased. As far as the tissue resident immune mediators in the endometrium are concerned, again, the similar kind of pictures are there. Immune activating factors are increased, and on the right side, the immune suppressing factors are decreased. Now, what are the therapeutic options? Again, oversimplified slide is that, on the maternal factor, if you find an anatomical defect or there is an hydrosalpinx, we do a self-injectomy or remove the fibroids, polypectomy, and, work on the endometrial growth, which should be basic, minimum should be 7. In thrombophilia, we give low molecular weight heparin. In genetics, people are trying their hand on ERA, PGS, and karyotyping. Immunological factors we have already using in the past. GCCF is definitely showing its role. IV, IG, PB, MCs are being used. Infections, we give antibiotics, and my friend Shivani is here. She's very fond of using ciproflox in the previous cycles almost daily on an intrauterine basis. And whenever there's an altered molecule and the endometrial receptivity is there, we again talk about scratching the endometrium and use of GCS in this. Again, as for the embryo is concerned, we can pick it up by doing a PGS and PGD. Male factors, we tell them about the lifestyle changes, especially they've been told to stop smoking. And we also try to optimize IVF protocol. So at least we should reach to blastocyst stage, because once they reach to blastocyst stage, at least 50% success is there in these IVF cycles. And the mantra of these days is that it should be a personalized protocols for each and every individual. Now coming to this particular one drug, thymosin alpha 1, it has got a direct antiviral and a tumor action, but at the same time it is big immunomodulatory, and probably this is what is being cached in this particular presentation. This thymosin is secreted by the thymus. This is a synthetic hormone, and it has got 28 amino acids. It modulates the innate immunity of an individual. This is the mechanism of the action, which I can summarize in just 2 lines. That immune dampening mechanism of action of TA1, that is thymosin alpha 1, has a feedback dampening effect on the immune system, leading to increase in regulatory T cells and decrease in the production of inflammatory cytokines, which create the havoc. As for the safety of thymosin alpha 1 is concerned, this particular product was available since 1979. This is US FDA approved. This is approved by the DCGI of India, and also 35 many countries more. 2,30,000 patients have been tried, more than that, and there are 2,000 published articles are there in PubMed. And this particular drug can be used, has been used in past in as young as 13 months old child to 101-year-old man. Can be used continuously or interruptedly for 12 months without any significant adverse effect, and has got a very, very low incidence of adverse effects. Now, the Gufic got an approval of manufacturing pharmaceutical formulation of this drug, and is responsible for distribution in this country. During the COVID time, they brought it in the form of thymosin alpha 1. And now this was immunosin alpha 1, and now they are marketing it as thymosin alpha 1. This original article is by Dr. Adarsh Shetty, whom I introduced you, that he is head of the medical division of Gufic, and this original article was on a double-blind, multi-center, 2-arm randomized placebo-controlled phase 3 clinical study to evaluate the effectiveness of safety of thymosin alpha 1 as an add-on treatment to existing standard of care treatment in a moderate to severe cases. And I just wish to tell you that, I have not purposely added 4 or 5 slides which Dr. Shetty had given. I can just summarize because my PPT was getting too lengthy. They found, once this particular drug was added on, the mortality rates of these COVID moderate to severe cases was 11% in comparison to 39% where the placebo was used. So there was a great advantage of 28% lives additionally could be saved. And all those parameters like ferritin, IL, interleukin 6 and all, which we got familiarized with during the COVID times, were used as parameters. And they found that the thymosin alpha 1 can lower death rate in severe COVID-19 patients, reduce the load on a hospital by shortening the required number of days of hospitalization, and decreasing the requirement of oxygen support, and thereby positively impacting the recovery rate and the time taken for recovery. Now coming to its use in recurrent implantation failure. Again, oversimplified is TH1 when we call is it is a pregnancy disaster. No pregnancy can go on. While TH2 is a pregnancy conducive environment, and there is a balance in life as far as this TH1 and TH2 is concerned. Now, TH1 response is characterized by production of interferon gamma, the marker for tuberculosis, a powerful cytokine that helps to activate macrophages and other immune cells. The main function of TH2 cells is to activate antibody mediated immune response. Th1 cells secrete cytokinins usually associated with inflammation, such as interferon gamma and TNF alpha, and induces cell-mediated immune response. I repeat again. The Th2 subset produces cytokinins such as interleukin 4, 5, and 6, and that help B cells to proliferate and differentiate, and is associated with humoral type immune responses. Now, whatever you can see is in blue is inhibitory, whatever you can see is in red is stimulatory, and you can see the interplay of Th1 and Th2 balance is concerned. Now, there are reports on which show that there is a low periconceptional maternal serum thymosin alpha 1 levels are associated with blighted pregnancies. The conclusion is that the decreased maternal serum thymosin alpha 1 levels may be associated with periconceptional endocrine and or immune disturbances preceding miscarriages. Another original article on the downregulation of ILT4 dendritic cells in recurrent miscarriage and recurrent implantation failure. The conclusion was that ILT4 plus DCs play an important role in the maintenance of immune tolerance during pregnancy, and probably through the induction of FOXP3 and T regulatory cells, a process which is impaired both in recurrent miscarriages and recurrent implantation failure. Uterine immunological changes may be responsible for repeated implantation failure, and the conclusion is that the modulation of immune system in RIF, recurrent implantation failure patient, is shifted to inflammatory responses as NK cells, Th1 signaling pathway and TLR signaling pathway are activated. Again, original article, endometrial NK cells subpopulation consisting of CD16, CD56, and CD in a woman with recurrent implantation failure. The summary is, again, the imbalance between CD16, CD56, and CD16 and 56 bright NK cells may have important functional implications in a woman with RIF, and could be used as a diagnostic marker associated with endometrial quality. Now, T cell subsets in peripheral blood of the woman with recurrent implantation failure, a combination of a higher pro-inflammatory Th1 and exhausted T regulatory cells, and a lower T regulatory cells and exhausted CD8 and T cells may coexist in the peripheral blood of the woman with recurrent implantation failure. Like me, everything must be going above your head, but these are the terms which, if you're not familiar with it today, you have to familiarize yourself in future. Another study had been done on the embryo implantation failure and recurrent miscarriage, talking about the cytokinin expression in the endometrium of women with implantation failure and recurrent miscarriage. The conclusion was cytokinins play a role in controlling endometrial, decidual, and cytotrophoblast cell function, and therefore defects in the expression of cytokinins and or their receptors are likely to result in implantation failure. You can see here, whenever there is recurrent implantation failure, all these parameters on the left-hand side have become abnormal. And as for the dysfunction in recurrent implantation failure is concerned, they almost get the reverse way. A single open label 2-arm frozen embryo transfer randomized study to evaluate the efficacy and the safety of thymosin alpha 1 as an odd add-on therapy to standard of care in patients with the recurrent implantation failure was started by GUFIC. And the study was a single center open label 2-arm frozen embryo transfer randomized study to evaluate the efficacy and the safety of thymosin alpha 1 as add-on therapy to standard of care in patients with the recurrent implantation failure. Now, there are 2 arms had been that used total of 37 doses 13 doses were used in FET cycle prior to ET, and again 24 doses were used after ET, twice weekly dosing for 3 months. So the total cycle will be for 3.5 months. But at the first phase, because they found promising results, they have started, informing people. The other day, they went to Bangalore and informed people. On the last Sunday, probably it was in Hyderabad, and today, through me, it is in Delhi. So what they're going to study is implantation rate, and then study it at the end of 6 weeks after the embryo transfer, then at the end of 12 weeks whether the gestation is continuing or not, and at the end of 14 days after the embryo transfer. The inclusion criteria had been to include females between 20 to 40 years, infertile women with a history of recurrent implantation failure, who had failed to achieve clinical pregnancy in which at least 4 good quality embryos were transferred. Female participants who had at least 2 top quality embryos appropriate for embryo transfer used. The female participant with a known ART failures or implantation failure that warrant no further ART program feasible. The exclusion criteria were female participant having any endometrial disease, female participant who have participated in another trial with an investigational drug within a month prior to this trial, female participant who, in the judgment of investigator, will be unlikely to comply with the requirement of this protocol, and the female participant with any other clinically significant illness in the option of the investigator that may jeopardize the study results. So in a frozen embryo transfer, one arm is using FET with thymosin alpha 1 plus the standard of care, while in the second arm only the FET will be done with the standard of care and no thymosin alpha 1 will be used. Now these are the 13 doses in FET cycle. Day 0, 2 injections will be given, then there will be gap of 2 days, then again 2 injections will be given. Every time there is a gap between the injection, there is a 2 days gap is there, and the last injection will be given almost 24 hours prior to the FET. These are the ones, the way total of 13 doses will be given. This is just the summary of the same 2 slides put together in the same slide. And these are the various parameters which will be recorded in detail, case record system, and you'll find there will be biochemical pregnancy, there may be clinical pregnancy, and there will be ongoing pregnancy. So we are empowering gynecologists with this particular new drug. There is something in the horizon, and this will help to enjoy the bliss of motherhood as far as this particular woman is concerned. So, sorry.
Thank you, ma'am, for all this deliberation.
So I think before we invite people who are experts, Brigadier Sharma, I think I'm going to ask Mr. Shetty to open his opening remarks, and it will be followed by Dr. Joshi's personal experience on the same before I give it over to Dr. R.K. Sharma. Mr. Shetty.
Yeah, thank you, ma'am. Thank you for the nice deliberation on the topic. It was quite a feast to watch your presentation. Coming to the product, the Thymosin Alpha, I'm studying this product from past 4 years. I think during the COVID times, which was a havoc during that time. I studied this product because there was an article from a very old article where this particular product...
Sir, still louder, please, sir. Louder, please.
Okay. I'm audible now? Okay. So I've been studying this product from past 4 years on this product during the COVID times, wherein this particular product was used long back, which was produced from thymus gland. So this is nothing but an endogenous peptide. So everyone who is listening to this particular topic has this particular hormone. So this is the endogenous hormone which is already present in the body. So usually after the age of 20 years, this particular hormone, thymus, starts shrinking. That everyone knows. This particular hormone concentration also starts decreasing after the age of 20. So during that time, I studied this in COVID times. So while studying, I came across that this particular hormone causes immune homeostasis. The beauty of the product is it brings the inflammatory markers to the baseline. It acts on both ways. If you study any other immunomodulators, it acts on only one way. That means either if you take a tacrolimus, either if you take glucocorticoids, it only acts on the one way. In this particular drug, the beauty of this drug is it acts on both ways. That's the beauty of this drug. While studying this drug, I came across that this particular drug works in cytokine storm. So for that reason, we did two trials with Dr. Pandit and Dr. Om Srivastav in moderate and severe COVID. We got the convincing results in Dr. Pandit's study in Fortis, Mumbai. All 15 patients survived. And in Dr. Om Srivastav Kasturba Hospital, Mumbai, we did around 15 patients. All 15 patients survived. So based on the preliminary results, we thought that we'll go ahead and do the phase 3 trial. I think Dr. Jain presented the study, that phase 3 trial of Thymosin alpha in moderate and severe COVID. So then we did it in moderate and severe COVID, and we did it in 120 patients, almost 2:1. During the design also, I took it 2:1 deliberately because the patients has to be benefited. So that's the reason I took almost 70 patients in the thymosin arm and 40 patients in the SOCs. So during that study, we got around almost one patient died in thymosin arm, and 8 patients died in SOC arm. So almost is 1:8 ratio. And also you should understand that it is 2:1. So 40 patients were in SOC and 70 patients in thymosin arm. So while studying the numbers needed to treat, which came across around 3.7. That is out of 3.7 patients, one patient was saving lives. So during this design also, I took the primary endpoint as mortality. Even if I check the remdesivir, they have taken it as a hospital number of days as the primary endpoint. So it's very difficult.
And this is the point when you got the emergency clearance from the government of India.
Yeah. Then we approached the DCGI. Then we got the approval from the DCGI. Then we started marketing this product. Everyone loved this product, and the cytokines. And to be frank, the TNF alpha was decreased, and CRP, these two parameters in this one section, it was decreased drastically. So during this trial also, a number of patients were endometriosis also were there, and they got relief. Based on that experience, we're working on endometriosis also, and we have approached DCGI for phase 3. And even in almost 10 centers, this particular trial is going on. Maybe it will take another 6 months. Based on the results, will come across to all of you once the results are convincing. That's how it came. Then the thymosin alpha, we studied it. We studied the parameters because in RIF, the parameters were almost opposite. Then we thought that we'll study this drug. Then we approached Dr. Joshi. Dr. Joshi willingly agreed to try this drug, and he will share his experience after me. Then rest is history. I can talk about the mechanism and all. Let Dr. Joshi give his initial comments.
Unmute yourself, sir.
Yes. Thank you very much, Shandama. Fantastic presentation. You said anything and everything about thymosin alpha. Now, as far as I'm concerned, how I came to thymosin alpha, I have been working on immunology of pregnancy loss and implantation failure for almost 10 years now. I've worked very extensively on TNF alpha molecule for almost 10 to 12 years. And then been through a lot of meetings of human reproductive association in Europe and Oxford. And I started lymphocyte immunotherapy 7-8 years ago. So a lot of immunological interventions I have been doing. I myself had very significant COVID and I came out of it. And then when I was recovering, when you have a lot of time, you do a lot of reading. So then I realized that most of the things in life or most of the things in pathology are mediated through inflammation. So I think I have come to a strong opinion that there should be a master's or MD in inflammation, like we do MD gynecology or MD whatever. We should have MD in inflammation because almost everything, the end pathway is in inflammation. May it be infective condition, may it be autoimmune condition, may it be trauma, may it be oncology, whatever. So when we have this T cell and B cell imbalance or different responses of T cell and B cell, then when the T cell responses are more, the cytotoxin, T cells are basically cytotoxin producing and B cell are antibody producing. It's as simple as that. So when we have higher incidence of T cell activity, which is measured by so many cytokines, so many markers, major reason why we do not do these markers is their cost. These markers are quite expensive to, I mean, even if you look at normal inflammatory markers, there are more than 17 inflammatory markers. The cheapest one is TNF alpha, which is about 4,000. So if you're going to investigate another 15, which is worth 4, 5,000 each, you're going to spend money worth 1 or 2 IVF cycles in just investigating and then treating it. So COVID also taught us the same thing. What happened in COVID, that people who had T cell immune response, which was stronger, had cytokine storm. And this cytokine storm damaged their organs, primarily lungs, because lung is the entry point of COVID, the virus. The concentration of COVID virus is more in the lungs, and that's why the local cytokine effect is more. That's why lungs were damaged. But also there was damages of brain and blood vessel and thrombotic, which we know. So one person is having T cell activity, is sick or ill with cytokine storm. At the same time, we could see that in the same family, another person also COVID positive, but he is doing normally because his T cell activity is more. And then what world did is went through lockdown, vaccinated everybody. Now, after vaccination, what happens is that we produce antibodies, which is a B cell activity. So, for that particular protein, the B cell activity, once it is more, then your organ damage or organ cytokine damage is less. So, similar phenomena happens in recurrent pregnancy loss. So when I was working with TNF alpha for last 10, 12 years and using very high amounts of uh, delta tocotrienol and pentoxifylline, the responses were very good. Even there was improvement in oocyte quality, there was improvement in endometrial thickness, because these inflammatory markers are ultimately receptor blockers. They block the receptor. So whatever hormones we give, whether it is the hormones to the ovary or hormones to the endometrium, the hormonal function goes down. Now, what thymosin does, it's basically a polypeptide, so it's a very safe. As you said, ma'am, it is a group of 28 amino acids in a particular sequence, and that particular sequence makes it a hormone and has to go and work on that sequential receptor which will accept it, and it works. So it will balance between the cytokine activity. To some extent, yes, we need cytokine activity, but if it is on a larger side or our cytokine response is more, like what COVID has taught us, that some people reacted to COVID virus with huge amount of cytokine storm, and some people didn't. So similar thing happens in pregnancy, and that's what all the research and the data which you very nicely and extensively presented showed that the level of thymosin alpha, in turn level of cytokine uh, factors. And then I started using it in patients, and we are getting very good results. I used almost in about 500-600 cycles, and the pregnancy rate is much better. So then we decided to do this trial. Now that trial is been approved by MUHS, that is Maharashtra University of Health Sciences. Their ethics committee is reviewing that. And then we'll do this trial, which I think doing 100 patients will take us a month or two. And yes, so now I'm open for questions. So this is a concept I wanted to put forth, that inflammation is one. Rather than running behind doing a lot of tests, if we do simple NK cell tests to see what is the number or percentage of CD3 and CD1656 dim. CD1656 are two types. One is bright and dim. Dim is a B cell. So, and CD3 is a T cell. So this is a very economical, very cheap test. Normally, we send it either to Ranbaxy or Metropolis, cost about 3,500. And if we see that CD3 cells are more, obviously, that means the T cell activity is more. CD1656, if they are less, then the B cell activity is less. And these are the candidates for using thymosin.
Sir, 500 cases is a huge number. What do you have to say before Brigadier Sharma chips in?
Yes, it is.
आपका क्या कहना होगा?
Sir, muted है.
Sir, I think that there's a issue is.
Sharma sir, you are mute.
Yeah, now
Sharma,
I'm
yes.
muted myself. Firstly, I would like to congratulate Madam to introduce this new molecule, and Dr. Shetty and you both working on this molecule. Recurrent implantation failure is a big enigma. Still, we do not know many times. Why the patient has got it, and suddenly in one pregnancy, she after 10 to 10 losses, she becomes pregnant and continues with the pregnancy and gives the live birth. So there are so many factors which are involved. So we cannot pinpoint one particular reason. That could be the reason why the patient having implantation failure or early pregnancy losses. But yes, as you mentioned, inflammation is one of the bottom line point which we have to observe whenever we are talking about recurrent implantation failure or early pregnancy loss.
Sir, mute हो गया फिर.
Mute हो गए आप.
Yeah. This is a new molecule which requires a lot of research and all. My just one or two questions are there. Since this is a polypeptide, do we, because this is given intramuscularly, isn't it? So do we need to give test dose, because some patients may develop anaphylactic reaction? Have you seen any reaction taking place because of that, Dr. Joshi?
No, sir.
So
No, we have not seen any even local reaction with that.
Like we don't like growth hormone we are giving it, without any test dose. So this also can be given without any test dose as far as the information is concerned. That because that would be in the mind of many people.
Insulin is like a polypeptide. FSH is a polypeptide.
Yeah. So this molecule also can be given without doing any test dose.
Yes, it can be given.
Now the thing is,
it is given
normally see the embryo is a product of a mother's genome and the father's genome. Mother's genomes are her own genomes. The uterus understands them and it would accept it. So it is the father's genome which is foreign to the uterus. And uterus is the only organ which allows this foreign genome to multiply and grow the whole embryo, which is foreign to the uterus anyway. That part of the the embryo and then the fetus is foreign to the uterus, and the nature has created, or the God has created an environment where it would allow it to grow, or it would be accepted by the body. And somewhere when this acceptance doesn't take place, it does not mother's genome no problem, but the father genome which is foreign to the uterus, and they say okay, this is foreign to me, and the body has got a natural tendency to reject anything which is foreign. So I'm not talking about thymosin as such. The father genome comes in contact with the the lady's system by the intercourse, isn't it? So whenever a couple is doing more frequently the intercourse, the more the small doses of the immunity is being created, so that the paternal genome will be now accepted. Like we are giving immunization, so that even if the corona comes in my body today, it will multiply, but it will not harm me. Okay. So thymosin is good, and as you mentioned, inflammation. This basically balances the inflammation so that implantation would take place. So we have to study this molecule more, and meanwhile, till such time we have a foolproof method that doesn't have a long time side effect on the baby's thymus also. That is also a very important thing. The other methods like more frequent intercourse and meditation in the woman, because meditation is known to decrease the inflammation. So that also is important. So to the public, I would say, general gynecologists, yes, we must, wait and watch, to see the long-term effect of thymus injections. It looks very promising as of today, and but what will be the effect on the baby's thymus? That also we have to see. We should not, develop antibodies against the thymus of baby itself. And in the meanwhile, we can advise them more frequent intercourse, so that the immunization of the female genital tract with the male genomes should take place, and the meditation can be added besides the dietary and the adequate rest, which also is
Fantastic, Brigadier. I mean, you have laid down 2, 3 different points. Now, one is to about adaptation to the paternal genome, and this is, I mean, if we look at the work done by Professor Christopher Redmond almost 30 years back when he started lymphocyte immunotherapy in Oxford. Professor Christopher Redmond. I was in UK for about 10 years, so I have fairly good interaction with the lymphocyte immunotherapy because I was one of the center modulator in Birmingham for the LIT trial which was going on. So that was the exact theory that mother would get used to the partner's genome, and that's the fundamental basis of LIT or lymphocyte immunotherapy, that you cross-match them, isolate lymphocytes from the husband, and then inject it to mother, and it works. Now, then that time, 30 years ago, the IVF prevalence on failed IVF prevalence was not as high as today because sheer number of cycles have gone up. Pre-COVID, there was a conference in Oxford about European Society of Human Reproductive Immunology. So I went there, and there was nice work presented by Professor Gavin Shacks, who is also a good friend of mine. He's in Sydney, Australia. So he presented a lot of data about how he used lymphocyte immunotherapy uh, in IVF. And after his talk, when I asked him that how many of these IVF cycles had donor sperms, so there were few cases who had donor sperms. So then the question comes that you are immunizing the woman with husband's lymphocyte, but using donor sperms genetically for whatever clinical reason it is, but it is still working. And it did work in those cases as well, that the mother was immunized by husband's lymphocyte and the donor sperms were used. So we are talking that there is probably another mechanism of interaction. And then it went on to say that when you have lymphocyte immunization or LIT, then your in general B cell activity increases. And when your in general B cell activity increases, the T cell activity goes down. So it is always a balance. Now, the second point which you mentioned about meditation and yogasana, the Iyengar Institute from Pune have clearly demonstrated that when you do pranayama, breathing, and yogic exercises, the life of thymus increases. And thymus is generally the longevity of the thymus gland, indicates the general health and longevity of a person. So what both points you are saying are absolutely right. There is a huge amount of work which has gone in, and that will, I think, help. With regards to forming antibodies to the thymosin or having effect on the baby is very, very unlikely. But I think we can always discontinue this by the time of 12 weeks of pregnancy, after which mainly the organogenesis happens. And this is only at the time of implantation and when the placenta sets in. That's the differentiation. Because these three molecules, the P27, cyclin E, and integrin, these three are responsible for attachment of the embryo, proliferation of the embryonic cells or the placental cells, and then differentiating that placenta into different types of cells. Because unless it differentiates the chorionic villi, unless it differentiates, it will not form a good. Because placenta has got blood vessels, placenta has got pools, placenta has got chorionic cells, etc. So I think it's good idea to discontinue it by 12 weeks of pregnancy when the placentation is complete.
And maybe the follow up of these babies,
Yeah.
long.
There will be follow-up of these babies, and it has to be a long-term study. But like any other study, we'll have to wait. But at the moment, these are right from lymphocyte immunotherapy to Professor Ridmiller to Gavin Check's work, and he famously called a multifactorial that is doing lymphocyte, then
Sir,
using
let's getting back to this particular drug here. There are many people who are very eagerly waiting to hear from you. 500 cases, I again repeat, is not a small cases. Are you tempted to use other than recurrent implantation failure also?
That's what I wanted to ask.
Yeah. Now what we do is uh, assessment of the uterus is important, because immunology is not the only reason for implantation failure. Like Brigadier Sharma said, uh, so endometrial thickness, endometrial vascularity. Generally, we see endometrium not 7 millimeter, but it should be 9 millimeter plus. The vascularity has to be up to zone 3. There is also a system of Appleworm scoring. It's a little complex, but these two, because many of the radiologists are not familiar with that. So we just recommend, okay, give us some roughly mid-luteal phase endometrial thickness and blood flow. It should be around zone 3. If it is not, then we improve that by doing hysteroscopy and angiogenic growth factors. So PRP is one part of it, but it has to be injected in a subendometrial area. Many people just push it in, but you should not push it in. You should inject it in the subendometrial area. Then only it will work. So if we feel that there is a implantation failure because of the immunological reason, and the immunological investigation, as I said, is mainly done TNF alpha and NK cell. In NK cell, we are looking at CD3 and CD1615. Those cases are given thymosin. Because if there is any other factor like poor embryo or poor endometrium, it's not going to help.
And Dr. Adarsh, have you thought of trying this drug in other chronic inflammatory diseases
Uh,
like chronic joint pains, autoimmunity, other diseases?
yes, yes.
Are
So this,
there trials or something
yeah,
going on?
yes. This drug has been studied in rheumatoid arthritis, and they've got the convincing results also. There are few articles published, and this drug has been studied in asthma also. And as I speak, and we are approaching the DCGI for sepsis. I think a few days back we completed the phase 3 study, and we got the very beautiful results. Even the mortality benefit was there in sepsis also. Sepsis, as we know, is inflammatory markers are quite high, and all the inflammatory markers are reduced. we'll be approaching this DCJ also. Maybe in a few weeks, we'll be getting the approval of this particular drug in sepsis also. And we are doing the trial in endometriosis, as I told before.
Even
Dr.
lymphocyte
Shivani?
immunotherapy
Anti-aging also.
works in immunotherapy works in endometriosis as well. So I got very few cases,
Dr.
4 or 5
Shetty,
cases
Dr.
where
Shetty, Brigadier Sharma is asking, what about anti-aging?
Anti-aging. And there are a few studies. It helps in alopecia also. We tried of topical formulation in for hair growth. It's still under investigation.
Because as you mentioned, after the age of 20, it starts decreasing in size. So that means the thymosin secretion must be decreasing.
Yeah.
So maybe I can plan to take it now and revert my age.
And it also has some effect in this, sperm concentration also, capacitation. It helps. The few studies, it's 30 years back published. This helps in the capacitation of sperms.
To Dr. Joshi, I just wish to tell you that, I was also very fond of LIT, and, because once the low molecular weight heparin came, I found, that particular work was taken up by that. But I was also very, very happy with recurrent miscarriages cases as far as this treatment is concerned. And here I wish to tell you, sometime if the gentleman husband goes away, say outstation, and nobody is there, his brother can also, his sample could also replace, and nothing happened, So this probably explains that there is another phenomena which also is taking place.
Yes. I mean, the original thought of Professor Christopher Redmond that it is gaining tolerance to the husband's genome is not probably true. So it works for sure, but we don't know the reason why it works. And the reason what we thought it works, I mean, it's like something working, but we don't know why it is working.
Last word, because I think we have to have a second presentation. What, you are the only person who has used the drug here. Nobody else has used it. आप क्या कहना चाहेंगे दिल्ली गाने वाले गायनोकोलॉजिस्ट को जो कि IVF experts?
One simple line: whenever we see a case of recurrent implantation failure, we analyze it in the formulation, whether it is maternal factor, embryological factor, or immunological factor. The simplest test we can do is NK cell test, which is very easily available, doing CD3, CD16, 56. If CD3 are on a higher side, CD16, 56 are on a lower side, those are the cases of recurrent implantation failure, and everything else is normal. They are the ones who will definitely benefit with this with a greater extent. But don't use it blindly, otherwise you'll get mixed results. It is not going to improve the quality of embryo or endometrial thickness or endometrial vascularity. It will only improve the cytokine milieu. At the most, you can also do TNF alpha to see whether the TNF alpha level is high. So thank you very much for having me here. So
Thank you. Thank you very
I would
much.
request all of you to excuse me because I have to rush.
Thank you, sir. Thank you so much. Thank you.
You all are welcome to Nasik. Nasik is a wide range of hilly place. It's not like Mumbai, though it is very close to Mumbai. We are up in the hills. We are about 630 meters from the sea level, and we have a wide spectrum of activities around. We have wine and we have divine, both. So there is Trambakeshwar, the Shirdi, Trambakeshwar, all the divinity is also there, and there is now it is wine capital of India. So I'll be very happy to see you in Nasik and accompany you from wine to divine, all the places. Thank you very
so
much.
Thank you.
Excellent
Bye-bye.
job. Thank you.
Dr. Shivani,
Thank
you
you.
want to say something?
No, ma'am, I just want to say thanks, Dr. Ranjit. It was so nice to get to hear. And this recurrent implantation failure is very frustrating problem. We face it almost every day. So thank you. Like there are some other options available.
Thank you very much.
Thank you.
Okay, you can continue. I'll take your leave and you can continue in next
Thank
session.
you, sir.
Please.
Thank you.
Thank you very much. Thank you.
So after this innovative session, now I invite Dr. Aruna Saxena for her talk. She is founder and director